Good morning, everybody. I'm really pleased to be here because quite a lot of my talks are to learned scientific groups who don't really understand the problem like you do. So it's a really good opportunity for me to relay some of the work that's going on in our field. And I work in an obstetrics department in St Thomas's Hospital as the academic side. And, you know, we look one way across the river to the Houses of Parliament, but we look south to Lambeth and Southwark, which are the boroughs which we serve, quite like Hackney in terms of the obesity problem. And we have a huge issue in obstetrics at the moment, and that's obesity. And it's become such a problem that someone said to me the other day, they think it is the major obstetric issue that we're facing in the United Kingdom at the moment. So I'm going to talk to you a little bit about the problems. As I see it, people are pretty much unaware of the issues about obesity and pregnancy, and that's not you, but our women, they're very surprised. I ran a study over the last 5 years in obese pregnant women, and one of the commonest issues was that they didn't know the problems that might happen to them during their pregnancy. They had no idea. So they're saying, I'm a perfectly healthy woman, and, you know, I may be a little bit overweight. You're telling me that there's something wrong with me, that I might have an abnormal baby, or I might have problems. Complete shock to people. And that I think, is one of the issues that we have to get across, because as I'm going to be going on to talk about, it's not just the problems in pregnancy, it's the long-term consequences. That's not my phone, is it? The long-term consequences of obesity that women aren't aware of, particularly the influence on their developing child. And pregnancy is a time when people are very receptive to information. We have found that. They really take the message on. They try and improve their diet and so on. But it's just the whole idea that there's something amiss is a real problem. I'm sure that we could do a lot more than we do as health professionals to help these women. So what's the extent of the problem? This was a Lancet review which came out earlier this year. And what it's suggesting is that by 2025 across the world, more than 21% of the women in the world will be obese. And if you look at the heat maps from 1975 to 2014, you can see there's an awful lot more redness around. And where the increase in obesity is occurring, actually it's already sort of pretty much got to a plateau in Europe and in America. It's happening in sub-Saharan Africa, it's happening in the Middle East, it's happening in places like Mexico, it's happening across the whole world. And the increase that we see, these red and orange lines are up here, are in low and middle income countries. So whereas it was once a problem just of high income countries, obesity is now becoming just as much of a problem in the low and middle income countries. A couple of weeks ago, I was in Johannesburg talking to a colleague of mine there who works in the hospital in Soweto. And the biggest problem they have in obstetrics now is gestational diabetes, and that's because there is so much obesity amongst their women. That and HIV together are a pretty grim combination. So across the world, there are a huge number of issues happening in relation to obesity, all of them not good amongst the obese population. So the other thing is, you know, unfortunately, current data suggests, and it has to be said this data isn't most accurate because we don't have good data about BMI in pregnancy in the European countries. Mostly it's sort of derived from rather inaccurate statistics. But as it stands at the moment, the EU tops the list of obesity in the UK amongst pregnant women. So we have the biggest problem across Europe. So I'm going to go through some of the issues that women face about reproductive health and obesity. One of the first that most people don't appreciate is infertility. So obese women, the BMI over 30, have taken much longer time to conceive. So if a woman has a BMI over 40, is more obese, she takes 7 times more, she's 7 times more likely to take more than a year to conceive when she's trying to have a baby than a woman who has a normal BMI. And also there's been some rather alarming studies looking at the eggs of obese pregnant women. So these are eggs which have been taken for infertility treatment, and those surplus to need in IVF, showing that if you look at those oocytes, they already have metabolic dysfunctions. This is before the embryo is developed, of course, before fertilization. So if you look at the mitochondria, which are the sort of powerhouses of the cells, they're abnormal in the oocytes before pregnancy. And then if you look at the early embryos, which people have done, again, embryos surplus to need in IVF, the embryos already show metabolic dysfunction before they're implanted. So there's abnormal transport of amino acids across the surface of the embryo. The metabolic dysfunction is apparent in relation to mitochondria and so on. And then women who are successful in IVF and become pregnant, they have 68% fewer live births than women who have a normal BMI. I don't think most overweight and obese women appreciate this problem. And maybe if people knew about this, there would be a greater attempt to gain a normal BMI or not to become obese when you're thinking about becoming pregnant. So other issues, I'm sure you're aware, women who are obese tend to miscarry more frequently. They have a higher risk of stillbirth. There's a linear relationship between BMI and neonatal death, and that's been done extremely well-conducted studies in large populations. And both very high and very low gestational weight gain are associated with infant death. Women who are obese are more likely to have babies who have congenital abnormalities. Part of that problem may be that because they're obese, it's very difficult to do ultrasounds, I expect you know, and you can't really see the developing fetus very well, and sometimes these abnormalities are missed, and therefore women don't undergo terminations when they might otherwise choose to do so. But there is also a risk because of the problem about hyperglycemia, increased glucose and relationship to gestational diabetes, that some of these defects are increased. But the biggest problem, and one which I've been focusing on in the last few years, is gestational diabetes, where there is something between a 4 to 9-fold increased risk of diabetes in obese pregnant women, developing during pregnancy, which is picked up at the oral glucose tolerance test, which should be carried out in obese women at 26 to 28 weeks of pregnancy. The sadness is that across the country we know that doesn't happen. The reason that it doesn't happen amongst all obese women is it's too expensive, because antenatal diabetic care is expensive. And in the UK at the moment, despite nice guidelines, there are very few hospitals which routinely screen all women with a BMI of over 30. Some of them focus on women with a BMI of 40 or even higher than that because of the cost issue. So there's a real problem there. The global prevalence of gestational diabetes because of obesity is increasing across the world. And one of the problems is in the developing countries that we don't really know what the GDM prevalence is because nobody's actually looked. But it's, as my experience in Soweto the other day, it's sadly very high. Then in terms of the baby, we all know that mothers who are obese tend to have bigger babies. So obesity is related to an increase in blood glucose. Glucose goes across the placenta. It stimulates insulin production from the fetal pancreas, and it's that insulin which stimulates growth of the fetus and overgrowth. So there are more babies born with a weight of over 4 kilograms, macrosomia, to obese women. And then because of that, there are all sorts of problems associated with delivery, such as shoulder dystocia when the baby's shoulder gets stuck, and then you get brachial plexus damage. Women often have to have induction of labour, and it's partly because the uterus stops contracting. There's some association between obesity and the contraction of the uterine muscle. Because of all of that, there's a very much higher caesarean section rate amongst obese women. And if you look at the caesarean section rates globally since 1990, they've increased from 6.7% of pregnancies to 19.1% of pregnancies across the world. Now, we don't know how much that's to do with local practice. Brazil, for example, has the highest rate of C-sections in the world. It's not entirely because of obesity, it's because of local practice. And then we've done a study of postpartum hemorrhage recently, looking at some big hospitals, our own hospital, another hospital in Kent, and there's been a dramatic increase in severe postpartum hemorrhage, which is associated with an increase in BMI. Now, I think most obese ladies don't recognise these problems. And I think as health professionals, we have a duty of care to make people far more aware that these are issues and to help people attain a normal BMI before they become pregnant. Another issue, I work in the field of preeclampsia quite a lot. I've just been to the International Society of Hypertension meeting this last week, and preeclampsia isn't going away, it's going up, and that is again because of obesity. Preeclampsia, we all know, has terrible effects potentially for the mother, including fitting and death and thromboembolism and so on, but also for the infant. And there's evidence now that a baby born to a woman with preeclampsia itself is likely to grow up with a higher risk of hypertension and cardiovascular disease. So it doesn't stop when pregnancy stops. And the other thing that we've found in our studies of obese pregnant women is that there's a very high level of depression and anxiety. And in fact, if you look in the literature now, this has been very well reported. We did a systematic review and we were quite shocked to find the high prevalence of depression amongst obese women. So what's this about? One thing that really concerns me, and having done an intervention study in obese ladies, is that because of the depression, there's a lack of self-esteem or whatever, one might follow the other. And women are not susceptible to advice when they're feeling low. The last thing they want to talk about is their weight. We all know that depression can be associated with changes in eating behavior. We should tackle these problems. There's a huge mental health issue. Lack of self-esteem. We need to be able to recognize this in order to be able to help women to change their diet and improve their physical activity and eating behaviors. And I think this is a completely unmet need in healthcare at the moment. And I think we all know women like this who have sort of given up on themselves and are eating a terrible diet and sort of comfort eating. And in our studies, we see single women on benefits with living in council housing within a pretty awful environment, and they are depressed and don't know where to go and they need help. So the problems don't end at delivery, and this is what we've been talking about. Atul has already suggested this association with childhood obesity. But let's talk first of all about breastfeeding. Obese pregnant women are less likely to be able to initiate lactation. Now, we think that might be due to a physical effect. Nobody really understands that, but very often they are unable to initiate lactation. There's no question that they have reduced duration of breastfeeding, so very few obese women make the 6-month WHO recommendation. Very few lean women do too. But actually, in our study of 1,500 obese pregnant women recently, we've shown a relationship between the BMI of the lady and the duration of breastfeeding. So the highest BMI group were those who stopped breastfeeding earlier. And the other thing which we showed, which I think is really important, I don't believe has been shown amongst a group of obese women before, is the huge difference in weight retention postpartum in those who breastfed and those who didn't. So those who managed to maintain breastfeeding were 2 kilograms lighter in weight than those who didn't. And I think this isn't recognised either. We all know that breastfeeding is associated with weight loss postpartum, but it is also in obese pregnant women. And so that's something we can all go out and recommend. And one of the interventions which we're proposing at the moment in the last European application I'm going to be able to make next February, will be an intervention study to support obese pregnant women and to help them initiate breastfeeding, which is going to be specialist care, one-to-one. We haven't worked out the intervention completely yet, but it is hugely important that we help obese ladies to breastfeed and get over the problems that they have. And then obesity, unfortunately, of course, is related to longer-term disease. So in the mother, obesity will continue and will cause problems. She's far more likely to get type 2 diabetes. If she's had gestational diabetes in pregnancy, she has a 5-fold risk of getting type 2 diabetes in later life. She's far more likely to suffer from cardiovascular disease than a lean person, and the mortality associated with that. This increase in type 2 diabetes after gestational diabetes has been very, very widely researched, and there's no question about it. And it seems to be that gestational diabetes per se conveys risk of getting type 2 diabetes in later life. So the health outlooks for the mum aren't too good if she maintains her weight. But today we're really talking about childhood obesity. And this is where I've done quite a lot of work in the developmental origins hypothesis area, which Atul was talking about earlier. And I'll take you through a little bit about this, because this is the most alarming aspect, in my mind, in relation to the next generation's health. So we think that maternal obesity independently affects the developing child such that that child is born with an increased risk themselves of developing obesity, and that is through biochemical processes. It's not through the fact that the child is born into the same environment as the mother, that the child is fed the wrong foods and so on. This is independent of anything of that nature. It is that there's an independent relationship between being developed in utero, in what we call an obesogenic in utero environment, and the development of obesity in later life. So what do we think's going on? We know that the developing fetus is very susceptible to humoral, environmental, endocrine influences. So I mentioned that glucose in the mother gets across the placenta, it stimulates fetal insulin, insulin causes the baby to grow, and it causes the baby's fat cells to grow. And a baby who is born fat is likely to become a fat adult. So the suggestion is that something happens to the adipocytes, the fat cells, that they retain the memory of the in utero development, and then the child goes on and becomes obese. I was sitting in a Medical Research Council grant funding round this last week, a very interesting study from obese mice, and I'll tell you a little bit about the work we've done in obese mice, showing that the obesity in mice is associated with obesity in the offspring and the same environment, the same food and so on, but that the cells, the adipocytes, retain the memory of obesity in the pregnancy by actually having more stem cells. More stem cells which create adipocytes are created, and they're there forever. Now, whether that's true, it's one study, but the suggestion is that the adipocytes retain the memory. The work that I've done using obese mice and obese rats, we've shown unequivocally that if you make a mouse fat and giving it delicious food to eat, and it eats away and it gets nice and fat, its offspring grow up fat, they grow up hypertensive, and we've shown that that is detected in the fetal brain. So the area of the fetal brain which seems to be most susceptible is the hypothalamus. The hypothalamus is the seat of satiety. So what we have shown is that the area of the hypothalamus which is associated with detecting satiety and stopping the offspring eating normally is adversely affected. It grows abnormally, and that the offspring is born with a predilection to overeat. So the normal satiety response is lost. We are looking at that now in children of obese mothers in some cohort studies, and we have a little bit of evidence from a study in Auckland in New Zealand that that is the case, that we've used what is called the Childhood Eating Behaviour Questionnaire to look at satiety in children, and those obese mothers, whereas their children had a slight increase in reduction of satiety. So those are the sorts of things which make us believe that this is not just a passing whim, that this is really important. And there's a huge amount of literature out there, if you look in PubMed and you look at some of the scientific papers, to suggest that the developing fetus is particularly susceptible to the environment of the mother in utero, and that will cause an increased risk for later life obesity. And this is the sort of evidence from observational cohort studies. I'll just take you through this. So this is the relationship between maternal overweight and obesity and childhood fat mass in children, not infants, but children who are beyond the age of 3, I think this was. And anything to the right of the midline, these are all separate studies, suggests that maternal overweight and obesity is associated with development of increased fat mass in the child. So the majority of studies, not all, this one suggests that there's nothing very much happening. The majority of studies suggest, particularly the bigger ones, that there is an independent relationship. And this is the mean of them all, which is way beyond the midline. So this is pretty good evidence. And there are many studies like that which suggest that maternal obesity independently when it's been corrected for socioeconomic status, the eating behaviours of the mothers, the eating behaviours of the children, the activity in the children and so on. That still remains an independent association. It's worrying. This is not sort of Darwinism, it's Lamarckism. It's the suggestion that you can acquire these defects intergenerationally. And there are quite a lot of studies like this. This paper came out just a few weeks ago, which you may have seen it in the press, that maternal body mass index was associated with newborn telomere length. This was a study in children, suggesting that obese mothers, the children might actually live up to 17 years less. It was a study actually which was carried out. It didn't actually show this. This is the journalists over-egging it. But what it did show was that if you took the cord blood, and I think it was the cord tissue from women who had obesity in pregnancy, that the telomeres, which are a marker of healthy life length, were shortened in the tissues from the children. So suggestion is that the children may not live so long. And actually, there is a big study which came out of Scotland which suggests that children of obese mothers tend to die earlier, and they die earlier from cardiovascular disease, so it's not so far-fetched. So what are we going to do about it? I don't have a solution to that, but I can tell you some of the things that we've been trying to do. So the study which we did in 1,500 obese women in the United Kingdom was called the Upbeat Study, and you can find that. It's well published in the literature. So what we tried to do with this was to advise obese pregnant ladies to improve their diet. The diet we chose was a low glycemic index diet, which is supposed to improve insulin resistance, because the main thing we were trying to do was to prevent the ladies getting gestational diabetes. We suggested they increase their physical activity. And the study worked to a degree, and this is the encouraging part, that this advice was delivered by a health trainer. That's somebody who had actually, mostly they'd worked in the community to deliver healthcare advice. We trained these ladies, the healthcare professionals, to deliver the intervention over a period of 8 weeks, and this was quite intensive. We asked the ladies to come to sessions once a week. And it was developed with psychologists. It was an evidence-based intervention, and it did show quite a dramatic change in the ladies' diet, which was great. They improved their diet quite a lot. Their gestational weight gain reduced. Their adiposity, by measuring skin fold thicknesses, reduced. But it was all in the right direction, but it just wasn't enough to prevent gestational diabetes or any of the other complications that we see in pregnancy. And several very large studies, this is one of the 3 big studies in the world which have done this, have shown very much the same thing. You can reduce gestational weight gain, but you can't reduce it enough by dietary advice or physical activity advice to be of any real benefit for the outcome of that lady's pregnancy, which is a sadness. So alone, these interventions, whilst they will be beneficial in improving the women's diet, and we also showed that the ladies at 6 months postpartum had still changed their diet, so that was good. So the message had really got home. But it won't prevent those complications in pregnancy. And the problem about this is that when an obese lady comes into pregnancy, she has a huge amount of fat mass already there. And whatever you can do over the period of 9 months is just not going to really touch the surface of that problem of having a huge increase in adiposity to start with. So it's the pre-pregnancy BMI that's the problem, and you're not within 9 months going to be able to improve the metabolic disturbances which are associated with that obesity adequately to reduce the problems that we see so frequently in our clinics. And that is unfortunately a message which I am putting across now, because this is what the literature is suggesting. So this emphasis on reduction of gestational weight gain is good, that people should not put on too much weight in pregnancy. I don't think the IOM guidelines suggesting between 5 and 9 kilograms are correct. I could go into that. They are woefully inadequately researched, but the suggestion to women that they should not put on too much weight is a good one. But the problem about it is that probably the best benefit is it will reduce postpartum weight retention, but the benefit to the clinical outcomes in pregnancy is that the evidence is really not there at the moment. So what are we going to do? So the suggestion has been that we should perhaps intervene early with anti-glycemic drugs such as metformin. 2 big studies have been carried out in obese ladies, all obese women of heterogeneous risk, and they've given them metformin and it has not improved outcome. My suggestion, and one which I'm working on at the moment, is that we need to target those women who are most at risk. So what we've also done from this study is we've worked out a little formula which puts together some risk factors early in pregnancy, which predicts those women who are most at risk. And I think that's really important. If we know and we can identify women who are really at risk, then we can intervene in them, and that might be more beneficial. The problem at the moment is, although we say there's a higher risk of obesity in pregnancy, it's only 70% of women, or 70% of women don't get any problems. It's only 30% who have the problems. If we knew who those women were, then we could focus our attention. And that's, it's just like preeclampsia risk assessment, prematurity risk assessment. It's where we should go in this field at the moment. And that's what I'm focusing on, to put this algorithm into use and see if we can intervene. We should try treatment with diet. We should try treatment with metformin too, I think, see if we can improve outcomes. But that's for the future. The trouble is that one of those, I said right at the beginning, one of the issues about obesity in pregnancy at the moment is that not everybody is screened as NICE recommends for gestational diabetes. We should do that. We should find resources for that as a country, and we should implement it and we should police it. Because I expect all of you all working in hospitals, you should ask what the policy is. At St Thomas's, where I work, and you might think that St Thomas's might get it right, being right in the middle of London, opposite the Houses of Parliament. We haven't yet implemented universal screening for obese pregnant women. I can't believe it, given that I work there and I've tried very hard. But that is very much what's happening across the country. It's just deemed to be too expensive. So we should improve NHS pregnancy diabetes care. That will reduce macrosomia in infants, and there's no question about that. That's the best way we know how to do it. If you diagnose somebody with diabetes, they're quite good at changing their diet. We all know that, and that can improve pregnancy outcome. We can treat with metformin, we can treat with insulin, we can reduce adiposity in the child. But we have to screen properly for gestational diabetes. As I say, I think we should focus on high-risk women. And the other thing is to aid gestational weight loss, post-gestational weight loss. But most importantly, what we should do is to prevent obesity in young women. And I mean prevent, I don't mean reverse, because, well, of course we should try and do that, but it's extremely difficult for people to lose weight and maintain loss of weight, as we well know. Generally goes right up again after a couple of years. We should, as a country, be preventing obesity in young women. So let's put a bit of meat on the bones about this. So what about postpartum weight retention? I do think this is a missed opportunity. We should encourage breastfeeding, but how are we going to do that best with obese pregnant women? I mean, we should implement what we know at the moment. There are good guidelines out there. I think midwives are extremely good at helping women start breastfeeding, and we should just make sure that is particularly focused on obese pregnant women. We are in St Thomas's and King's College London doing a study at the moment which is to help women lose weight postpartum after weaning by recommending that they go to a commercial weight loss program. This is an NIHR funded study which is going to see whether that works. So what we're going to do is to pick up women towards the end of pregnancy who've had gestational diabetes, who've put on a lot of weight, or who are obese, and we're going to say to them, would you like to come and join in this program 6 months postpartum when the baby is weaned, and then take part. So we don't know whether that's going to work, but I think that is an opportunity because GPs could refer women to these weight management programs. The other thing about weight loss after pregnancy is that it will have benefit for the next pregnancy, and that I think is hugely important. If a woman loses weight from one pregnancy to the next, she's far less likely to get gestational diabetes, she's far less likely to get hypertensive disease. There's a huge literature on that. There's some fantastic studies from Scandinavia which have shown that even if a small amount of weight is put on after pregnancy, even sort of 2 to 3 kilograms, the risk of all of those disorders in the next pregnancy, C-section, neonatal death, stillbirth, birth, gestational diabetes, hypertensive disease, all increase if women put on a very small amount of weight between one pregnancy and the next. Again, I don't think people understand that. You don't have to have a high BMI to start with for that to be effective. You can start with a normal BMI, put on 2 or 3 kilograms between pregnancies, and your risk of abnormal pregnancy goes up in the next pregnancy. So that is something we could do something about. And it's something, again, which I think is largely ignored. So what about focusing on preconception interventions? And this is really where we have a problem. One of the big issues, of course, is that we don't usually see young people very often, apart from preconceptional advice or contraception advice. So a group of us have got together and we are trying to formulate a sort of pathway of care. But, what we need to do is to target women when they go for contraception advice, when they go for pre-pregnancy counselling advice. But how do we do this? It is really difficult. Schools, obvious target. But most young people are not interested in their health. This is a big issue. They don't want to be taught about disease or anything like that. They are just healthily ignoring. They think that they're always going to be healthy. We all know teenagers are like that. And they don't realise the risks of obesity. Whether teaching them about it will actually change their behaviour, I don't know. And I am amongst those who think that I've been appalled at the childhood obesity plan in common with our previous speaker. I was so hopeful that this was going to bring in some parliamentary advice which was going to make it law to bring in physical activity in schools, to take fast food outlets away from schools, so on and so forth. To tackle the food industry is absolutely essential. Because it is so difficult for wonderful people who are working, for example, in Hackney, fantastic studies going on, fantastic interventions. You need money, you need support, and you need the government right behind you. And I think it's been a deplorable turn of events that this government has chosen to ignore it. So people need to appreciate this, that of course we need to improve awareness, but we need the support. Many young people have very poor levels of health literacy. Women may not access health care until a bit late in pregnancy. And as I said, the developing embryo is already abnormal by the time they're actually asking for antenatal care. That probably the early pregnancy is one of the most important times. So it's preconception. We're not going to see people in the first few weeks of pregnancy, but we need to make sure that their health is optimal around the time of conception. I'm sure that would make a huge difference. So to go back to what we've heard about before, my opinion is that we really need to make policymakers much more aware of the problem, but they need to act on it. And I think things have improved to a degree in the early life side of this because, actually the childhood obesity plan suggested starting to prevent obesity in children when they were toddlers. Too late. There was nothing about the first 1,000 days of life. It was all too late. What a shame that was missed. Even that 9-page document, it was missed. But other of our publications have actually picked this up, which is good. So the Chief Medical Officer, Sally Davis's report, and she's my heroine, she's fantastic, Sally Davis. She's really helped us in this field. Her report, which was published in 2015, it's a 2014 report, was published at the end of last year, really picked up the problem about maternal obesity, about preconceptional obesity. The whole of her report was about this. It was about the fact that we should focus on trying to get our young people thinner, focusing on the problem that we have to start in pregnancy in early life. And this was, one of the diagrams that we put into the report. I helped write this with a lot of other of my colleagues. The idea that if you have a high risk trajectory in early life, that is, you're born with a high birth weight, or you're born to an obese mother, or you're born into an obesogenic environment, you're set on an exponential track for non-communicable disease risk. That's hypertension, diabetes, and so on. But the important thing is that this is a cyclical, that by the time you get to adolescence, and this not only applies to mothers, but there's some evidence that paternal obesity also affects the sperm in a way that the embryo will be predestined to obesity in later life, that it becomes cyclical, it becomes a vicious circle. And that message is incredibly important to get across. Then the WHO produced a very good report earlier this year, Ending Childhood Obesity, and they've really taken this on board too. It doesn't mean it's going to be implemented, but at least there's some way there. And they've understood the life course of events and the fact that one needs to intervene at every time of life. So to start off with promotion of healthy foods, promoting physical activity, preconception and pregnancy care, it's there for the first time in WHO reports. Good to see it, but it doesn't mean it's going to be implemented. They appreciate early childhood diet. They appreciate the whole of the importance of intervening throughout the whole life cycle. So at least it's there. It is a big step forward. They've also said we've got to diagnose and manage glycemia and gestational hypertension. Thank goodness that somebody has seen that and that it's out there in a respected WHO report. Monitor and manage appropriate gestational weight gain, very important. Additional focus on appropriate nutrition and guidance to mothers and fathers before conception and during pregnancy. So all the right messages are beginning to come out. This is the first year this has happened. Truly, this is the first year it's happened. It's never happened before, and we're delighted to see it. And just a couple of weeks ago, this report came out. And if you really want to know the nitty-gritty of the background, the scientific evidence for this, this is quite a hard read, but it's worth it. It's been very well researched. It's a bit inaccurate in places, actually, but it's pretty good. And I only saw this week. It really goes into the transgenerational effect of obesity, the importance of preconceptional health. And one or two things, they did a survey in this, and this is really worth looking at. And this is one of my bête noires, one of the areas I think we can do a lot about. They asked 53 member states from the WHO European region, all sorts of questions about health professionals, who delivers advice to pregnant women, who delivers advice to women postpartum, and so on. And lots of important questions like, do you have specific dietary recommendations and nutritional counselling for at-risk groups, including pregnant women with a high BMI? And look at it, 35 to 40% only do have specific nutritional advice recommendations for these people. It should be up here, shouldn't it? And I'm afraid that's the same in the UK. We don't excel. We don't excel in our education about nutrition for health professionals. I think it's quite poor. We don't excel in our specific recommendations for at-risk groups. We tend to treat women very much the same. I know we have recommendations for women with BMI over 30. I'm not too sure exactly how they're implemented, and I don't think it's particularly good from my own experience. Physical activity recommendations. Do you have physical activity recommendations and counselling for special cases during preconception and pregnancy? Not too good. So this is the level that this is the level of advice that we're dealing with. What about training for healthcare professionals? Training, is it in service or is it pre-service? An awful lot of it's pre-service. So midwives tend to only get nutritional education during their undergraduate courses and their degrees. I'm actually looking into with our midwifery colleagues at the moment, the curriculum for nutrition in pregnancy in the UK. I think it's woefully out of date, and they are revising the curriculum at the moment, so perhaps we have an opportunity to do something about it, because it would be really good to get it up to date, and there's lots of good advice that we could help with. So I'm trying to see if we can provide some help to improve the nutrition curriculum. So there are all sorts of areas where we can improve. We need to make preconceptional health of women of reproductive age a public health priority. It's not there at the moment. We are engaged in a Lancet series, which will help, I think, which is all about preconceptional health, which will come out next year. We've just written, and you might like to see it, a series about obesity in pregnancy in the preconceptional period, which came out about a month ago in Lancet Diabetes and Endocrinology. And it's a really useful group of papers if you want to learn the background and also to spread the word. Very useful, up-to-date research documents. We've got to strengthen the commitment at the time of pregnancy prevention, pregnancy planning, pregnancy preparation to inform people. Really important. Bring data together. We need the evidence. As I said, we don't have routinely collected BMI in pregnancy. It's pretty inaccurate, the stuff that we got, and the HES records. We need to improve that. We need to promote health literacy about the importance of the preconception period. We need to engage young people. But the problem about it is, and as I say, awareness alone is not enough. And we've got some wonderful things happening at the local community level. Fantastic, increasing awareness, helping it. We've got to create the opportunity for integrated health and other sectors. Policy priorities are incredibly important. But what underpins all of this really is to have some money to support it. That has to come from government, as we've heard today. We have to have government right behind us. And sadly, at the moment, and I stick my neck out here, I don't feel they're really, really behind us in the United Kingdom. It's such a tragedy. But without that vis arter go, without the support from behind, we're on the back foot. And as we, local community council funding has gone right down. It's not going to help this problem. We've got to change it. So just to conclude, we know that obesity in pregnancy is associated with multiple health problems for the mother and infant, and I really think that is not widely appreciated. And as health professionals, we can go out there and do something about that. We don't need to alarm people too much, but some women who are obese, their children are at risk of obesity. These issues are very poorly understood by young people, mothers and healthcare providers. We must increase awareness. But above all, the solution requires action at multiple levels. Everything that we do is good. Everything, we mustn't stop. The advice that nutritionists give, the advice that midwives give, it all adds to helping. But we need governmental support. So I'm going to leave it at that. Thank you very much.